Welcome, everyone. My name is Stacy Ward. I am the interim CEO for PWS USA, and it is my pleasure to introduce to you guys our first speaker of the evening, Dr. Jennifer Miller. She is going to provide us with the didactic session of this ECHO. So Dr. Miller is a professor of pediatric endocrinology at the University of Florida. She graduated with her MD from the University of Florida in 1998 and her clinical investigation from the University of Florida in 2005. The majority of Dr. Miller's research efforts currently are focused on identifying the etiology and possible treatment for hyperphagia and Prader-Willi syndrome. She's been working with individuals with PWS for over 20 years. She currently follows, I don't know how you do this, Dr. Miller, 400 patients from around the world. And she is thankfully still working on developing clinical treatments for individuals with PWS of all ages. Dr. Moris Angulo will be doing our case study a little bit later in this presentation. So we'll do his introduction a little bit later. If you want to take it from here, you're more than welcome.
Okay. So thank you so much for that introduction, Stacy, and thank you for asking me to do this. It's my pleasure to do it. So if I can figure out how to make the slides move, that would be good. There we go. All right. Those are my disclosures, just research funding only. I don't do anything else with companies. And so I'm going to do a very, very brief overview because you all probably all know Prader-Willi, so 2 slides, and then talk about the endocrine stuff for newborns, childhood, and then adolescents and adults. So Prader-Willi syndrome is a contiguous gene syndrome with multiple distinct clinical features. There's a loss of function of at least 10 genes in this area, but the function of each one of those genes is still not yet known. And the SNORD116 loci is a major locus for obesity and hyperphagia. So the classic characteristics of Prader-Willi syndrome are low tone, endocrinopathies, hyperphagia, and obesity, behavioral problems, cognitive rigidity, learning issues, skin picking, and excessive daytime sleepiness. Obviously, these all don't have to be true. And in today's world, a lot of them are not true, but some of them are still problems, like the endocrinopathies that we're going to talk about. So these are the various nutritional phases that Dan Driscoll and I described back in 2011 that individuals with Prader-Willi syndrome go throughout their lifespan. So they start in what we call phase 1A, and that's where they have to have assisted feeding. So like an NG tube or a G tube or widening the nipple of the bottle. And then they go into phase 1B, somewhere between 3 and 24 months, where they are growing fine, eating fine, they have normal appetite and satiety cues, and they're eating entirely by mouth. And then around 2 years of age, they can enter what we call a nutritional phase 2A, which is weight gain without a change in calories. So the weight precedes the change in appetite. And then phase 2B, which happens around age 5 or so, is where the interest and awareness of food goes up. And thus they become more opportunistic about sneaking food when they can. And then phase 3 is the sort of the classic phase of Prader-Willi, where they are hyperphagic and rarely feel full. And that lasts through adulthood. So newborns, I bring your attention to the gator hat because this kid's from Virginia. So I was very impressed with the way that they got in to see me by putting a gator on his hat. And so newborns, the average age of diagnosis right now is 1.2 months of age. Early diagnosis allows obviously proactive counseling about medications, supplements, diet, exercise, research. And we know that the most important and best thing we can do for these infants in today's world is to start growth hormone therapy before 1 year of age. So growth hormone therapy has been shown to improve cognitive function and behavior in Prader-Willi syndrome. It also, of course, improves body composition by decreasing fat mass and increasing lean muscle mass, and improves respiratory parameters. It also shortens that nutritional phase 1A, the need for assisted feeding. And so early treatment may decrease the need for G-tube placement in the newborns. All right, so this is the big thing I wanted to talk about is sleep studies in babies with Prader-Willi syndrome. Are they necessary or not? So growth hormone, we know, has been associated with sleep apnea in individuals with Prader-Willi syndrome due to growing of the tonsils and adenoids from the growth hormone therapy. The current recommendations, which unfortunately I wrote back in 2008, are to do a sleep study prior to starting growth hormone therapy, refer to ENT if sleep apnea is present, and don't start growth hormone if sleep apnea is present. However, In infants under the age of 6 months, the presence of the obstructive sleep apnea should not be considered a contraindication to beginning growth hormone therapy. I have submitted this article. It is not published or accepted yet, but it's submitted. And so because this is an important change in how I think people should manage babies with Prader-Willi syndrome. So obstructive sleep apnea in these very young children is because of low tone. They have low tone. They can't their respiratory muscles are not strong enough to overcome their weak airway collapsing on itself when they're sleeping on their back. And so growth hormone therapy is only going to improve that low tone and thus improve the obstructive sleep apnea. Also, central sleep apnea is common in infants with Prader-Willi syndrome, and that's due to a problem with the ventilation and inspiratory drive, so they don't respond until their levels of carbon dioxide get much higher than other individuals before they take a breath. And that also improves with growth hormone therapy. So my current recommendations are that under 6 months of age, you don't have to necessarily do a sleep study. Adenoid tissue only becomes a problem after 7 to 9 months of age, and tonsils at 15 to 16 months of age. Because that 7 to 9 months and 15 to 16 months is a little, nebulous in terms of, some kids could get it like 6.5 months or whatever. I do say under 6 months for this no sleep study. But over that, yes. But under 6 months, I don't think it's necessary because growth hormone is only going to improve what you're seeing on the sleep study. And so, this is my current recommendations, especially if they've been in the NI, which most of our babies have been, and they've been monitored while they're there. And if there's no evidence of desaturation, then while they're sleeping, while they're eating, whatever, then they shouldn't need a sleep study before they start growth hormone. There is now an FDA approved Owlet, which is like a home pulse oximeter, or you can get a pulse oximeter from the pediatrician if you're worried or the parents are worried. But overall, I feel that growth hormone is very safe for these very young infants and should be instituted as soon as possible. The growth hormone actually stabilizes blood glucose levels, which is why I think that it also helps with IQ in these young infants, because we know that from a study that we've done that infants with Prader-Willi syndrome do have more frequent hypoglycemia that's unrecognized than other individuals do. And so by stabilizing the blood glucose levels, I think that helps with IQ, because repeated low blood sugar can't be good for the developing brain. But growth hormone can unmask central hypothyroidism or central adrenal insufficiency, because growth hormone increases your metabolism. And when you increase your metabolism, you increase the need for these other hormones like thyroid hormone or cortisol. And so for some individuals with Prader-Willi syndrome, growth hormone treatment can unmask these previously not diagnosed conditions. And so they need to be monitored for on growth hormone therapy. I generally recommend monitoring thyroid function every 6 months. It's important for people to know, because I've seen a lot of kids from other countries recently, and they come in with a TSH that is not adequate for monitoring the thyroid function. Sorry, my phone went off. And so it needs to be a total T4 or a free T4, because that's the only way to diagnose central hypothyroidism. Adrenal monitoring is a little bit more controversial, as the test has some false positives and false negatives. Some individuals, especially those in Europe, opt to treat as if adrenal insufficiency is there during significant illness or surgery, just to be safe. This is the art of medicine. So everyone does this a little bit differently. A lot of people still do a low dose ACTH stimulation test to check for adrenal function. But my concern about that is, just because the baby passes the test, then it doesn't mean that this won't develop down the line after they've started growth hormone therapy, or as the dose of growth hormone is increasing as they age. The other thing is hypogonadism. This is, of course, very common in Prader-Willi. It's the most common thing other than growth hormone therapy, or growth hormone deficiency, in infants with Prader-Willi syndrome. And so the boys can be treated with HCG therapy prior to 6 months of age, which allows for a normal mini puberty of infancy. So all children should go through a mini puberty of infancy. In boys, that means that their testes produce testosterone. When you give them HCG therapy, this actually allows the testes to produce their own testosterone, which is normal, and we want normal. This improves the size of the scrotal sac of the penis, and it can help testes descend as well. I tell parents all the time, I don't the testes dissension part is not the biggest deal to me. The biggest deal is that the scrotal sac gets bigger, so there is a place for those testicles to sit when the orchiopexy is done. I think that's very important. A lot of older kids you'll see have had an orchiopexy, and the parents are like, the testes still aren't there because there's just no place. The scrotal sac is so hypoplastic, there's no place for them to sit, so they ride back up in the inguinal canal. So I feel that this has benefit, even though it's not going to bring down the testes in most people. And for female infants, no one's investigated any treatments of hypogonadism. So it's my favorite picture of all time because this little girl just hates the heck out of me every time she comes in. Her mom swears she doesn't cry otherwise, other than to see me. So we're going to switch over to childhood because I only have 20 minutes. You don't get a lot. You get the brief. In childhood medications and lab monitoring, I usually recommend that labs be monitored every 6 months. The biggest thing here in childhood is that we all know that IGF-1 levels and IGF-BP3, its binding protein levels, go up significantly after a year of growth hormone therapy in children with Prader-Willi syndrome. So by the age of 2, most individuals with Prader-Willi syndrome will have really high IGF-1 levels. And a lot of endocrinologists say, well, we've got to bring that down because there's a risk of a high IGF-1 increasing your risk for things like cancer. The problem is that this is not an accurate way to look at growth hormone therapy. So the recommendation from the Dutch group many years ago was to calculate a molar IGF-1 to IGF-BP3 ratio to get what they're calling the free IGF-1 levels, which is your bioavailable IGF-1. This is what matters in growth hormone therapy. So the total IGF-1 that we measure on a regular basis is going to be high, but that doesn't necessarily mean we necessarily have to adjust the dose of growth hormone to bring it down. If there's no evidence of overgrowth, this high IGF-1 shouldn't prompt a dose reduction necessarily. And so free IGF-1 exists in equilibrium with bound IGF-1, and 99% of the IGF-1 is bound up. So we want to look at the free because that's what's bioactive, and that's what we're looking at for growth hormone therapy is what's bioactive and available. So because it's impossible to determine tissue bioavailability, it is impossible to determine tissue bioavailability and the therapeutic efficacy and safety of growth hormone dosing from just an IGF-1 or BP3 level alone. So that's why the Dutch group has recommended doing this ratio. And this is a very blurry table that I tried to cut from their paper, but there's a formula that you have to use. I have it stuck on my computer because I'm very bad at math, and so I have to calculate it every time. And then there's this table which has normal ranges for age and pubertal stage. And so that's what you have to do when they start to go high, rather than just reacting to the typical, to the IGF-1 level itself. And so what's interesting is that several groups now have showed that the bioactive form of IGF-1 doesn't actually increase beyond normal range in growth hormone therapy in Prader-Willi syndrome. Even though the total IGF-1 does, the bioactive one does not. So I thought that was very interesting. And there are definitely discrepancies between that total IGF-1 and that ratio. So that's why we recommend doing the ratio. And so the use of the ratio actually makes it possible to optimize growth hormone administration to try to minimize adverse effects and to augment or to improve those good effects from growth hormone therapy. So it's known, and this is where this idea of lowering the growth hormone dose because of the high IGF-1 comes from. It's known that IGF-1 in high concentrations is associated with certain types of cancer. And so there's a concern about those high IGF-1 levels. In contrast, high IGF-BP3, its binding protein levels, have protective effects against cancer. So in Prader-Willi, what we see is that they're both high. And so they're kind of the yin and yang of one another. And so ultimately, again, the ratio, which gives you that free IGF-1, ends up being normal for most individuals on growth hormone therapy with Prader-Willi syndrome. And so, the IGF-1 and BP3 do have effects on metabolism as well, which is why we want to maximize growth hormone dose to maximize efficacy without overtreating or causing problems. So, interestingly, the one thing that's been consistently found to be associated with a high ratio, so a high free IGF-1, is hyperinsulinism, which is very common in Prader-Willi syndrome starting at around age 2. So around age 2, this is a graph from one of our previous studies that shows that around age 2, when the individuals enter nutritional phase 2A, their fasting and their post-meal insulin levels start to increase. This is nutritional phase 2A, which I mentioned before, which is the weight gain without a change in calories, particularly in response to sweet taste. And this continues to increase over time. And you can see in this little graph that at the left or right there, there's nutritional phase 3, which has the highest insulin levels. And so those insulin levels continue to increase over time. Because individuals with Prader-Willi have an increased sensitivity to insulin, the high insulin levels cause problems for them. So they increase adipose tissue, increase craving for sweet taste, and ultimately then start to increase interest and awareness of food around age 5, which is nutritional phase 2B. Sorry for the noise. Other metabolic changes that occur as insulin release increases, it starts to create leptin resistance at the blood-brain barrier. This is not unique to Prader-Willi. This is everybody who has high insulin levels. Leptin levels then rise significantly in an attempt to get this signal to the brain of satiety. So leptin is supposed to tell you you have enough food, you have enough fat tissue. But when you've got leptin resistance at the blood-brain barrier, that cannot happen. So because the leptin doesn't get all the way through to signal the brain for this. So as a result of that, there's an increased interest and awareness of food. So the insulin starts first, that's phase 2A. Then the leptin resistance occurs, and that's phase 2B, where they develop an increased interest and awareness of food. So because of this, and because this just continues throughout life, the diet that we recommend is very much just a well-balanced diet that we should all be on, but we are not, using only complex carbs to mediate that insulin response, always pairing the carbs with a protein or a healthy fat to mediate the insulin response, and balancing out everything. We also recommend not doing like a very low carb diet. This was very popular for a long time in Prader-Willi syndrome, but too much of anything in Prader-Willi causes the insulin to go up, the fat tissue to go up. And so this is not recommended also because it will increase the insulin response. But in addition, it's just not sustainable for most people for their lives. And so it's not recommended. And then we also say, don't schedule snacks. We actually very strongly recommend this, that snacks should be given when needed, not on a schedule, because we don't want to feed the clock. We want to feed the child when they need it. And so, and then the other thing is we say no carb only snacks or meals because of the insulin response. We need to balance them with a healthy fat or protein to mediate that insulin response. And most importantly, and the biggest problem that we see in all of our kids is sweet tasting drinks. Most people with Prader-Willi syndrome do not like to drink plain water. And as a result, parents do tend to take action because they worry about dehydration. And so they put stuff in the water, just a splash of juice or just a little Crystal Light, a little lemonade. The problem is that sweet taste on the tongue starts that insulin response immediately as soon as it hits the tongue. And one time, not going to hurt you. Repeated exposure to those sweet tasting drinks and having that insulin continue to go up, up, up each time you have them, which is obviously multiple times per day, that's what ultimately is going to drive the hyperphagia. So the more that this whole cycle occurs, the faster the hyperphagia comes on. And weight. Adolescents, I just like this quote because, my girls were adolescents once. And so, during adolescence, we age a lot faster than our children do because adolescents are hard. And I think particularly with Prader-Willi syndrome, adolescence can be a very difficult time for both individuals and their parents because of all the hormonal changes that happen along with puberty. So premature adrenarche is very common in Prader-Willi syndrome, especially so pubic hair starting at before age 8. Very, very common. And that is thought to be probably due to the hyperinsulinism as well. But premature adrenarche or hair growth doesn't mean premature puberty. Puberty is often delayed and it's typically incomplete. So most individuals with Prader-Willi syndrome will start puberty, get to about Tanner stage 3, and then stop and need some hormonal supplementation to get them the rest of the way through. The general recommendations are to do this to help, particularly with bone mineral density. My problem with that is every kid is an individual, and you really have to base this treatment based on the individual person. There are some young girls and women with Prader-Willi syndrome that are so obsessive compulsive that it is just not a good idea to give them a period. It just becomes a very ugly situation for everyone involved. There are some boys with Prader-Willi syndrome who have no spatial awareness, and having them have erections of, within the very close context of females in their class, is also not a great idea. And so again, it's individualized. A lot of people benefit from hormone replacement in adolescence, just not everyone needs it. I mean, it obviously would be beneficial, but we don't want to cause more problems than doing good. We want to, obviously help them be as healthy as they can be without causing more problems for the individual. Estrogen, we typically replace for females using the Turner syndrome protocol, which is a standard protocol that endocrinologists use. And testosterone, I have found from my colleagues who do transgender care, when I learned that testosterone cypionate can be given sub-Q once a week rather than intramuscular once a month, it's changed my world, because this sub-Q testosterone actually doesn't cause nearly the amount of behavioral problems that we saw with intramuscular testosterone, because you're not giving them that big slug of testosterone that you have to give them when they get it intramuscularly. So doing it subcutaneous, starting at 25 milligrams once a week, has really been excellent for most of my male individuals with Prader-Willi. It's been great. It helps their bone mineral density, and they don't get behavior problems from it. So there's also protocols to use HCG, which we talked about in infancy. There's protocols for sub-Q HCG for adolescent males. And some parents prefer this to actually giving testosterone. When you give testosterone, the testes shut down and don't have to function because you're replacing, what they're supposed to be making. When you give HCG, it allows the testes to make the testosterone on their own. So it's considered a little bit of a gentler way of inducing puberty. And some families really prefer this way, this protocol for HCG, versus giving testosterone supplementation. And so my adults, obviously drinking is an issue. We say you may have hard alcohol, you may have red wine, and you may have beer, but that's it. No sweet tasting drinks, even when you're an adult, sorry. So the most important thing for the adults, in my opinion, is remembering that hormone replacement remains important for these adults throughout their life. I think it's really hard when individuals with Prader-Willi become adults to find an adult endocrinologist who's willing to continue these therapies and who understands Prader-Willi. But I do think it's critically important for their overall health and well-being that these therapies are continued. Also, there's a very high prevalence in adults with Prader-Willi of low T3 levels. T3 is your active thyroid hormone. So T4 is what we measure in the blood. Typically, T3 is what T4 is converted into at the end organs. This is actually very commonly low in adults. I mean, it's like 70% that it's low. And so we actually now recommend monitoring T3 levels in adults and replacing it if necessary. As individuals become adults, obviously the weight is often more difficult to control because parents no longer have complete control over the diet. And so thus, because of that, the prevalence of consequences of obesity like type 2 diabetes, hypercholesterolemia, hypertension do increase. And so these labs do need to continue to be monitored. We don't want the adults to go without endocrinology care because it's important that all these things be monitored and treated. Again, it's just hard to find an adult endocrinologist who is Moris or me. No, I'm just kidding. And that's it. That's Freya. She climbed to 10,000 feet or whatever that is last week. I just wanted to show that, anything is possible. So her mom didn't think it was going to be possible. She was very worried about her, and she did it with no problem.
That is very cool.
Did I do it in 20 minutes? I was pretty close.
You did great. So I do know there's a question in the chat, but if people want to unmute themselves and just verbally ask questions, that would be great. I'm going to change the view a little bit so that we can see everyone. But please go ahead and unmute. The question in the chat was, do you have a dose for the HCG treatment?
There is a protocol. So if whoever asked that question wanted to email, I can send you the protocol because I don't remember the dose. Quite honestly, I don't use it very often, that protocol. It's only been a few families who have opted to do that because it does start out at twice a week shots of HCG. And so, but it is sub-Q. Again, it's not intramuscular like for the babies, it's sub-Q HCG, but it's still twice a week plus the growth hormone shot. So a lot of kids actually opt to do the testosterone therapy versus the HCG therapy because of that. But I can send the protocol to whoever wants it.
Okay.
Jennifer, I can make, hello?
Hello.
Go ahead, please, Morris.
Hi, and I just some comment that I'm really very impressed how quick you covered the whole endocrine evaluation in Prader-Willi syndrome. Well, first of all, you really speak very fast, which is wonderful.
I know.
Otherwise, you cannot really cover it.
I know, it's a problem.
But in any event, first about the testosterone. In the subcutaneous form of testosterone is not the cypionate, it's the enanthate.
Well, you can do
the cypionate
sub-Q
is
as
only
well.
comes IM.
No, you can do cypionate sub-Q.
Yeah, and the sub-Q now is already
Yeah, you can do a
available.
sub-Q.
The sub-Q.
Yeah.
I know the Yostat is the enanthate, and that only can be used after the age of 18. And I agree with you, and I'm glad that you mentioned it because the level that you reach, they're very stable. It's better than when you give it every 2 weeks or once a month. I hope in the future everyone is going to be with the enanthate subcutaneous, but many insurance they don't cover that. That's the problem that we have. And now I don't know you having that problem.
Yeah, but testosterone is pretty cheap. It's only about $12 a bottle, which will get you at 25 milligrams, will get you 4 doses out of a bottle. As you go up on the dose, it's less. But
mile, 10 ml, very cheap. But the subcutaneous, it's a very difficult to get the approval, but that's really wonderful. Excellent, Jennifer, thank you.
Thank you.
Before we move into the case study part, does anybody have any other questions? All right, thank you, Dr. Miller, much appreciated. So Dr. Angulo is going to present a case study. He is, as you just heard, also an endocrinologist. He published the first study on growth hormone deficiency and response to growth hormone therapy, as well as the near adult height achieved in PWS after growth hormone. His publications, as well as those of many other clinical investigators, have played an important role in the FDA approval of growth hormone treatment for children with PWS without the need of stimulation testing. Dr. Angulo is the Director of Medical Genetics at Good Samaritan Hospital here in New York. He's a Pediatric Endocrinology attending at Good Samaritan Hospital and an Associate Professor of Clinical Pediatrics at the School of Medicine, Stony Brook, New York. All right, Dr. Angulo, if you would like to start to present the case study, the floor is yours.
Okay, thank you. Well, that was excellent review, Jennifer, and I think what I'm going to do is just to complement your talk with some practical evaluation and some cases studies, some of the typical one or some of the one that can give us somehow difficulties. We know that the most important factors to initiate or to monitor growth hormone treatment in Prader-Willi include bone age, length, height, weight, IGF-1, IGF-BP3, as Jennifer was saying. Thyroid function testing is extremely important. Glucose, insulin, and sex hormone profile just before the adolescence. And two practical points that I want to mention is just to let you know that height and length are completely different. Height is shorter than length, and that is because gravity brings your body down. And the other important is that we learn in endocrinology that to measure an very accurate height, we use the stegometer along with 4 contact points. That is the head, the shoulder, the buttocks, and the heel. But I want you to take into account that in obesity, you cannot always use all these 4 points. And regardless if you have or not Prader-Willi, and you will see here Oh, sorry. And I don't know what happened with my screen, but I can only see half of the screen. Okay. I still, anyway. So then you could see the right side, someone obese, sometimes the only contact could be the buttocks. If you try to use at least 3 contact points, you're not going to measure an accurate height. So you have to be extremely careful when you have obesity and measuring the height. This is a classical example of growth hormone deficiency and growth hormone treatment in Prader-Willi. The clinical features, they are very classical with neonatal hypotonia, lethargy, and gavage feeding due to neonatal feeding difficulties, and failure to thrive, followed by excessive weight gain after the age of 2, normal growth velocity thereafter, and delayed psychomotor development associated with temper tantrum. The mid parental height in this parent was 66.5, and so we expected her to be close to that. She was seen by pediatric endocrinologists at the age of 5 with excessive
Hey,
weight gain.
Morris, can I interrupt for just 1 second? Could you hit slideshow on the screen you're sharing? It'll be easier for everyone to see your slides.
Are you seeing it, the slide?
We're seeing part of it, but not all of it, similar to you, I think. If you click on slideshow at the top.
Let me see, let me just check this one here.
Okay.
How about now?
Oh, better, much better. Thank you.
Okay. So now she was seen by pediatric endocrinologists at the age of 5. At that point, you could see in the growth chart, she had excessive weight gain and decreased growth velocity with psychomotor developmental delay, and the height was already in the 8.5th percentile, whereas the weight was about the 97th percentile. All the clinical features during that evaluation, they were very classical of Prader-Willi, including fair skin, skin lesion from peaking, hypotonia, central obesity, narrow forehead, thick saliva, and small hands and feet. Now, she was diagnosed at the age of 2 with normal chromosome analysis, but she had abnormal chromosomal microarray with deletion type 1. At the age of 5, the bone age was equivalent to 5 years, and she had normal IGF-1 and IGF-BP3. Remember, the IGF-1 and IGF-BP3 are just screening, but they are very helpful also for growth hormone deficiency and to monitor the growth hormone levels. When she was diagnosed with Prader-Willi, she was started on the usual dose of growth hormone, 0.24 milligram per kilo per week, divided 7 days a week. She was followed with IGF-1, IGF-BP3, bone age, thyroid function testing, and decreased caloric intake. As Dr. Miller was mentioning, they need to be followed with thyroid function testing. She developed hypothyroidism at the age of 7, so she was started with levothyroxine. At the age of 13.5, after measuring the sex hormone level, they were below the normal range, she was started in sex hormone therapy. At the age of 16, she underwent growth hormone stimulation testing as an adult and started the growth hormone treatment as such. She had normal bone mineral density, and in the right side, you can see the excellent response to the growth hormone with normal adult height, as well as the lipolytic effect that Dr. Jennifer Miller was mentioning of the growth hormone. I know what the problem was is now. Okay. IGF is the most widely used parameter for screening of growth hormone deficiency, as well to monitor the growth hormone dose when someone is getting growth hormone therapy. It's very interesting that when they report the result of this IGF-1, they usually give you the actual value along with a standard deviation. This standard deviation that is extremely helpful to know if your child is getting too much or too little growth hormone. For instance, if the standard deviation is more than 2, it's getting too much growth hormone. And if less than 2, it's not getting enough. And between -2 and 2 means normal levels. All the hormones in the blood usually circulate in a free and a bound to a protein. And the free hormone is the active one. In the case of growth hormone, you can see it circulates in the free form and the one that is bound to a protein. The free form is the one that is going to go to the liver. It's going to stimulate the liver to produce not only IGF-1, but also acetylαμide subunit and IGF-BP3 that eventually form this ternary complex that is going to release free IGF-1 and combine form with the protein. Now, people ask, why do you do IGF-1 instead of growth hormone to see someone is producing enough? Simple reason. The most important one is that most of the metabolic and anabolic effect of the growth hormone, more than 80% of that effect is done by the IGF-1. And the second one is that the growth hormone is released in a pulsatile way. So the levels varies a lot during the day, whereas the IGF-1 is very steady. So it's better to use it as a screening. The free form that you see here, which is only 2 to 3%, is the actual active IGF-1. It's the one that is going to do the effect, anabolic and metabolic, of the growth hormone. And when we measure the total IGF-1, we measure in everything. We measure in the free form as well as the one that is combined to the protein, which is about 85%. 58% of the variation in response to growth hormone is due to variability of IGF-1, mostly IGF-BP3. Remember, free IGF-1 is the bioactive form, as Dr. Miller was mentioning, and the current lab measures the total IGF-1, IGF-BP3, but doesn't do the free IGF-1. Yes, both of them are growth hormone dependent, but IGF-1 is more closely regulated by growth hormone than IGF-BP3. So therefore, the bioactive IGF-1 can be calculated using the IGF-1, IGF-BP3 molar ratio. And okay. I don't know what's going on. Okay. Now, the IGF-BP3 molar ratio is more useful as a marker of safety of growth hormone treatment than IGF-1 alone. This is very interesting and recent study, perhaps the only one that I am aware of, where they were able to measure in prepubertal as well as pubertal children with Prader-Willi while receiving growth hormone to measure the levels of free IGF-1 compared with the molar ratio and total IGF-1. You could see in green, that is the free IGF-1 and the molar ratio. Both of them, they were either normal or low, whereas the total IGF-1, that's the one that the lab normally does, it was high in all of them. So therefore, we know that the free IGF-1 or IGF-BP3 molar ratio should be considered when the IGF levels are greater than 2 standard deviation. Now, in terms of figuring out what is the formula to use the molar ratio, I see that the formula that Dr. Miller was showing, and I'm very familiar with that formula, but honestly, I have more difficulties in trying to calculate the molar ratio using that formula. And I was very lucky that I had one of the medical students that is a guru in statistics, and he just figured it out with this formula. And I can tell you, it worked the same than the other one, and it's very easy. It's just the IGF-1 divided by IGF-BP3 using the same units, nanogram per ml, times the constant of 3.61, and it gives you the same molar ratio than the other more complicated formula. And this is a typical example of someone with Prader-Willi that was growing at a normal rate, gaining weight normal, that it has high IGF-1 and IGF-BP3. So the question is, do we change the growth hormone dose? Are we going to decrease the growth hormone dose? And the answer is no, because when you figure it out, the IGF-1, IGF molar, BP3 molar ratio is normal, and you can see is now factors as well as the anabolic factor. The most important are the growth hormone and the sex hormone. Whenever we have a child that is naive growth hormone deficient, isolated growth hormone deficiency, we usually give the growth hormone until the bones, they reach the full skeletal maturation, at least very close to it. And that's when so by the age of 18 to 20, the peak bone mass is the best. That's what really happened in girls. And by the age of 18 to 23, that's when the boy, they reach the best peak bone mass. Now, that is when we're talking about someone who has isolated growth hormone deficiency that produces enough sex hormone. However, in Prader-Willi, this peak bone mass is not reached with growth hormone alone. So that means that we had to add the sex hormone therapy, and it had to be added at the right time. If you look at this graph here, that's with the growth hormone, IGF-1, and sex hormone peak levels are in 24 hours. All of them, they had the peak in late puberty. What that really means is that when you really need the combination of the growth hormone and sex hormone, but not only that, sometimes we may have to even give higher dose of growth hormone to mimic what normally happens in the human body. So it's not unusual that around puberty, Prader-Willi may need a little bit higher dose than the standard one. And this is a beautiful study where they were just given growth hormone alone in prepubertal children. In the top, you can see there was significant increase in bone mineral density in different parts of the body. When the same group of children, they reach puberty and they keep on giving density, even so there is no improvement in the bone mineral density. Based on that, we believe that clinicians should start sex hormone therapy from the age of 11 years in girls and 14 years in boys, unless they have normal sex hormone levels or progression of puberty. I just want to give you the last case because it's very fascinating. It's a 11 and a half years old girl that came to see the endocrinology because she had decreased growth velocity, and you could see here in the growth chart. However, the bone age was 15 years. So the question that we have here is, should be treated as an adult or as a child? And let me give you this. You look at the bone age of 15 here, and if you bring this line here, you can see that when the bone age is 15 or more than that, they reach a plateau. There is no more growth after that. So the answer is she had to be treated as an adult. And that's exactly the way that she responded. You could see the response. She didn't increase in height anymore, but we really were getting the anabolic effect of the growth hormone. And we have to be sure that we have to stop the growth hormone when the bone age is equal or more than 14 and a half years in girls and 16 10.5 in boy. Why couldn't give on this child the regular pediatric growth hormone dosing is because if we give that, only the distal part of her body, they were going to get big. Their hands, their feet, their chin, the eyebrows, etc. That's called the acromegaloid features. And that's why she had to be treated as an adult. And just to finish, the androgens that come in either from the gonad, testicles, or ovary, or the adrenal gland, they normally go through the fat and convert in estrogen. Now, the gonads may not contribute that much, but as Dr. Miller was saying, premature adrenarche is very common in Prader-Willi. So the adrenal gland, they're going to give enough androgen that in the fat, they're going to be aromatized into estrogen. So the estrogens, along with the growth hormone, they're going to work at the growth plate in the bone, and eventually they're going to fuse it. So in summary, we can say that increased fat androgen aromatization is going to advance the bone age, and therefore we're going to stop growing sooner. Thank you.
Thank you, Dr. Angulo. Is there any questions or any comments that anybody would like to make?
Well, it looked like everyone understood or they didn't understand at all.
Might be a combination of both. I know I got a couple chats asking if you guys would be willing to share your contact information in the chat so that people could reach out directly to you.
Yeah, that is okay, because there are so many problems that we can have when we given the growth hormone. It's just not simple, straightforward. Like Dr. Miller was saying, in the past we used to use mostly IGF-1, but now we have the tendency to use the molar ratio, and hopefully in the future we're going to have an assay for just free IGF-1. Because that's the most important. Like, you look at what she was mentioning about what's the follow-up. She mentioned total T4 and free T4, because free T4 is most important. And the same thing that the growth hormone, the free growth hormone is the one that binds to the receptor, and the free IGF-1 is the one that is going to do the growth hormone effect.
All right.
Moris, I just want to say I'm personally grateful for that simple formula. I took a picture of it. I'm going to put it on my computer. Much easier.
It's easier. I don't really, honestly, I don't know how he did it. I didn't care, but I did.
As long as you did it, right?
I figured it out. I compared that formula with the one reported. And then I said, it's the same. And I said, it's easier.
I love that. That's fantastic. Easier for math is better for me because I suck at math. So thank you.
And I really like it. Yeah.
All right. Well, if there are no other questions, I just want to thank both of you for your time and everybody who is here with us for joining us. Much appreciated. We will be sending out the recording and sometime next week to everyone who registered. As I mentioned earlier, we had over 70 registrants for this. So I think what we're going to end up doing is a survey to get a better idea of what is the best time for people to attend. I think we get a lot of registrants with the hope of getting the recording afterwards, but the goal with ECHO is really an all teach, all learn. So we want people here participating so that they can continue to learn as well.
Yeah.
All right. Thank you guys very much. Appreciate you.
Oh, thank you. And
thank
the question, Stacey, you can still submit it to us.
Okay, perfect.
Okay.
All
thank
right.
you.
Sounds good. Thank you. Bye-bye.
Thank you. Bye-bye.